Okay. So last session we finished some aspects of coma. An extension of coma is brain death. So we shall approach that. That topic is slightly important these days because there is a lot of organ transplants. So we shall approach that as definition, diagnosis, and what are the messages of this brain death. So just to recap what is coma, because it's an extension of the same. According to Plum and Posner, consciousness is a state of full awareness of self and one's relationship to the surroundings. It is having content and depth. We have seen it in detail in the last session. The content, as you know, is a hemispheric function, and depth is a function of the ascending reticular activating system. And so that is consciousness. And coma is defined as a deep unconsciousness from which the patient cannot be aroused even by painful stimuli. That is coma. But how does coma differ from brain death? In brain death, it is irreversible. Whereas in coma, it may be reversible. So that is the point. So we saw what is consciousness, what is coma. Coma may be reversible, but brain death is irreversible. And what is this minimally conscious? Here is a person who is severely impaired in consciousness, but definite behavioral evidence of self or environmental awareness, like flickering of the eyelid, sometimes trying to show yes or no, some kind of sounds, some purposeful behavioral response like crying. So even though patient has no motor response, no verbal response, some minor activities which give hope to the relatives, that we call it as minimally conscious state. So now there is a coma, which we have finished in the last session. And whether it is conscious, whether the patient in coma is going into consciousness or brain death. So either a comatose patient can become all right, or he can go into brain death, or he can go into persistent vegetative state. Neither becoming conscious, not showing brain death. So persistent vegetative state, last session we have seen that patient is awake, some kind of eyelid movements are there, nothing else, and it remains more than 3 months, then you call it as persistent vegetative state. And so comatose patient becoming conscious, he can go into a minimally conscious state, that we saw the flickering, some kind of gesturing, some kind of sounds, crying, or they can go into good recovery. For example, if the coma is due to hypoglycemia or some drugs, they may go into good recovery. Or they may be left with disability. Supposing it is a hypoxic ischemic cardiac arrest, a cardiac arrest coma resuscitated in time, they go into disability. Whereas drugs and metabolic, they go into good recovery. And partial insults, they go into minimally conscious state. And 3 months, only eye movement is persistent vegetative state. And nothing is there. That is brain death. So next, so now we come to the definition of brain death. So we have seen consciousness, coma, and what are the courses a comatose patient can take. And now let us see if brain death happens what. So brain death is defined as irreversible, whereas coma may be reversible. Brain death is irreversible loss of all functions of the brain, including the brainstem. And the 3 essential findings in brain death are coma, absence of brainstem reflexes, including apnea, and irreversibility. Very vital, because if a person has got a reversible coma, you should not remove his organs. So the 3 essential findings are coma, absence of brainstem reflexes, including apnea, and irreversibility. So what are the prerequisites for defining brain death? We have seen the parameters. Patient should be comatose, he should have apnea, and he should not have any brainstem reflexes, and the same thing should be irreversible. So now what are the prerequisites? We are going to categorize these 4 parameters. One is etiology of the unresponsiveness should be known. So if you do not know, sometimes it may be some electrolyte imbalance, hypoglycemia, patient will come back after some time, and you should not remove his organs. So etiology of the unresponsiveness should be known. Before you call somebody as brain death, you should know the cause of it. Second, exclusion of reversible causes. All reversible causes should be excluded. And absence of motor or verbal response to pain, no seizures, no brainstem reflexes like pupillary response, oculocephalic reflex, corneal reflex, cough reflex, gag reflex, and oculovestibular reflexes. None of these reflexes should be there. And reflexes mediated by cranial nerves, like corneal reflex, conjunctival reflex, are absent, whereas spinal reflexes may be present. Some of the tendon jerks may be present. And two assessments at least 6 hours apart. And these parameters should remain without changing at least 6 hours apart in adults. In children, it is more than 24 hours. So 6 hours apart, it should remain constant. After the second report of the same parameters, you can do what is called apnea test. So the prerequisites, there should be no hypothermia. So patient's target temperature should not be in hypothermic range, and patient's temperature should be warmed to 36 degrees. So before we suspect brain death, aptis people and all those things we have seen. But these are also criteria. There should not be any hypothermia, and temperature should be warmed to 36 degrees. And if the person has taken any sedative drugs, if he has not taken, it is okay. If he has taken, you have to wait for 5 half-lives of the drugs taken to see the serum levels and then decide whether the drug is the culprit. Then if the patient has taken paralytic drugs, again, if he has not taken, it is okay. But if he has taken curar like neuroparalytic poisons, then you have to wait for 5 half-lives and then use neurostimulants to prevent the toxic effects of the paralytic drugs. Then if there is hypotension, we have to use vasopressors or inotropic infusion to maintain blood pressure to optimum level. And severe, there should be no acid-base imbalance. The PCO2 and PO2 should be normalized by supply of oxygen and correction of acidosis. And hypoxia should be corrected with oxygenation. So before we declare brain death, basic parameters should be corrected. Otherwise, it may be hypothermic unresponsiveness or paralytic drug-induced unresponsiveness. All those things should be corrected before we. That is another prerequisite. Then you have to look at the pupillary. You look at the eyeball's position, then pupillary responses, gag reflex, then pharyngeal reflex. Then you can look for the oxygen, fully oxygenate and prevent the correct all the metabolic parameters which we just now went through, that is hypothermia, hypotension, hypoxia, hypoglycemia, all that should be corrected. So what are the brainstem reflexes? Pupil. So now examination of the pupil, we all know how to examine the pupil. And if the pupillary reflexes are abnormal, it may be a problem in the afferent pathway or the efferent pathway. So this goes through the various structures. Anywhere it can be affected. So pupil is one of the parameters. Oculocephalic is when you move the eye to head to one side, eyeballs move to the opposite side. So that is a sign of integrity of the brainstem. So that you have to check oculocephalic reflex. In an unconscious patient, it is easy. In a conscious patient, will shift his gaze. So it will be difficult. So oculocephalic is tested. Then vestibulo-ocular is by syringing the ear with the cold water. And you know the cold water will produce nystagmus with a fast component to the opposite side and slow component to the same side. So that indicates the brainstem is all right. If that is not there, brainstem is dysfunctional. Then you look at the corneal reflex. Then you look at the cough reflex. You look at the gag reflex. So these are the various brainstem reflexes. And we have seen that one of the prerequisites, apart from the metabolic parameters, which we just now saw, the next prerequisite is brainstem reflexes should be absent. So pupil, oculocephalic, vestibulo-oculocephalic, corneal, cough and gag, which is depicted in the picture also. So those things should be absent. So if this is remaining like that, 6 hours apart in an adult, you can prepare the person for the apnea test. Before preparing the patient for the apnea test, the core temperature should be 97 degrees Fahrenheit. And systolic blood pressure should be more than 90 millimeters. U volumia should be there. And PCO2 should be more than 40 millimeters of mercury. And normal PO2. And you can do a pre-oxygenation to obtain an arterial PO2 of more than 200 millimeters of mercury. So before going for the apnea test, we have seen various brain cortical features, various brainstem features. If those things are remaining constant 6 hours apart, prepare the patient for apnea test. For apnea test, these are the prerequisites: blood pressure, temperature, volume, PO2, PCO2 should be normalized. Then rule out any underlying lung disease. Because patients with lung disease will also have altered PO2 and PCO2. That is not due to brainstem. Ensure euvolemia by positive fluid balance in the prior 6 hours. And terminate the test if during the apnea test preparation, if the patient goes into hypotension or hypoxia, you should not carry out the test. And respiratory movements or rise in blood pressure indicates functioning lower brainstem. So it is done after the second examination. So you have now how to prepare the patient for the apnea test and why not to proceed if there is some alteration in the blood pressure, oxygenation, or if the patient has got a lung disease, then this test will yield results which cannot be relied upon. So it is done after the second examination. Euthermia and euvolemia should be ensured. And oxygenation is done with 100% oxygen delivered through a nasal cannula to keep arterial PO2 more than 200. And you can ventilate the patient with 100% oxygen for 10 to 20 minutes to bring the PO2 to 200. And disconnect after ventilating the patient for 10 to 20 minutes, disconnect the ventilator. And then continue oxygen at 6 liters per minute through a nasal catheter. So initially ventilate for 10 to 20 minutes, then disconnect the ventilator, put a nasal catheter oxygen and continue apneic oxygenation for 8 to 10 minutes. That is up to PO2 of 200. And ventilated patients have PaO2 above normal and PaCO2 below normal levels normally. And elevated threshold for respiratory center stimulation is a PaCO2 more than 50 to 55 millimeters of mercury normally stimulates the respiratory center. If the PaCO2 goes to more than 50 to 55, if the respiratory center is intact, it will stimulate that. So patients with normal respiratory center may be apneic after disconnecting the ventilator if the respiratory muscle paralysis. So you should remember, if there is an end organ paralysis, that is a myasthenia or neuroparalytic disorders, then it will apparently look that there is no respiratory movement, so that you should be careful. And arterial PO2 more than 60 millimeters of mercury or rises more than 20 millimeters of mercury from the baseline and no discernible respiratory effort happens, apnea test is declared positive. So in the absence of a neuroparalytic disorder, in the absence of a pulmonary disorder, when the PCO2 has raised up to 60 millimeters of mercury or it rises to 20 millimeters from baseline, if there is no respiratory effort, you declare the apnea test positive. You have to prepare all the temperature, all the metabolic parameters, pre-oxygenate, initially through ventilator, later to nasal catheter, exclude lung disease, exclude neuroparalytic disorders, and when the PCO2 is more than 60 or it rises from the baseline to more than 20 millimeters of mercury, if the respiratory center is not stimulated, with all these prerequisites, apnea test is positive. So that is the next level of test. So brainstem reflexes we saw, cortical functions we saw. Then we have done the apnea test now. And then other supportive tests are transcranial Doppler shows small systolic peak without diastolic flow or reverberating flow, to and fro, pendulous flow in the basal vessels, indicating very high vascular resistance associated with greatly increased intracranial pressure. And EEG, transcranial Doppler shows no diastolic flow. And EEG shows absence of electrical activity of more than 2 millivolt for at least 30 minutes, with EEG meeting the technical criteria set by the American Electroencephalographic Society with at least 16 electrodes. Other tests, angiography, conventional computerized tomographic magnetic resonance or radionuclide angiography, there will be no intracerebral filling at the level of the carotid bifurcation or circle of Willis, whereas the external carotid circulation may be present. So external carotid circulation may be there, but intracranial circulation should be absent. Then we have got transcranial Doppler. So you have to use absence of diastolic or reverberatory flow. Using the transcranial Doppler, you show that absent diastolic or reverberatory flow and small systolic peak. And this is sensitive up to 77%, but specificity 100%. And MRI, loss of gray-white distinction in T1 and supranormal gray-white distinction in T2 and loss of flow voids in intracranial vessels and sinuses. MRI is less reliable because it fails to demonstrate the velocity of the flow. And radionuclide scintigraphy, it is done with 9-alpha-fluorodeoxyglucose or 99-hexametazine hexamethyl propylamine oxime. Inject within 30 minutes of reconstitution. It should not be kept. It should be freshly prepared and injected. And bedside SPECT imaging with the portable gamma camera is done. And empty skull. So there is nothing inside the skull. That is what you will find in the cerebral scintigraphy with the radionuclide injection. SPECT will show absence of technetium uptake. That is otherwise empty skull or hollow skull phenomena. And somatosensory evoked potentials. Brain death is confirmed by bilateral absence of N20 to P22 response with a median nerve stimulation. That is somatosensory response obtained from the cortex is absent. And EEG recording, how are you going to do? We saw the recommendation with the showing less than 2 microvolts. So a minimum 8 scalp, minimum 8, 16 is preferred. Minimum 8 electrodes should be used. And inter-electrode impedance should be less than 10,000 ohms, but more than 100 ohms. And test of integrity of recording system by deliberate creation of electrode artifact by manipulation. So all electrode artifacts should be removed because the waves we are going to record are very small. And inter-electrode distance of at least 10 centimeters should be there. And no activity with a sensitivity increased to at least 2 microvolt per millimeter for 30 minutes with inclusion of appropriate calibration. So nothing more than 2 microvolt discharges should be seen for 30 minutes to call it as brain death. The use of 0.3 or 0.4 second time constant during the part of the recording. So time constant should be kept as 0.3 or 0.4. And recording with an electrocardiogram and other monitoring devices, such as a pair of electrodes on the dorsum of the right hand to detect electrocerebral response. And test for reactivity to pain, loud noise, and light. And recording by a qualified technician. Repeat record if there is a doubt. And telephonic transmitted electroencephalograms are not appropriate for determination of electrocerebral silence. So it should be directly seen by the expert. Next is somatosensory evoked response. Median nerve, as we have seen, it should show absent parietal response. And the auditory evoked response should show only one wave. Out of the 7 waves, only one wave should be seen. That's the peripheral wave. And you have got a brain death format. This involves certification of the brain death by a board. It contains 2 aspects. One is just certifying brain death. And Form 8 is for certification for organ donation. So 2 forms. One is brain death certification for removal of life support and Form 8 for removal of organs. So as per the Transplantation of Human Organs Act, that is THOA. It is called Transplantation of Human Organs Act or THOA. brain death should be declared and form number 8 should be signed by 4 doctors before withdrawing life support measures and taking organs for transplant. So life support can be removed if the brain death is declared, and organs can be removed if only the form 8 is signed. So the people who are expected to sign are registered medical practitioner in charge of the hospital in which the brain death happened. An independent RMP nominated from the panel of names approved by the appropriate authority. So another registered practitioner should also be there. Then a neurologist or a neurosurgeon should be there. And the practitioner who is treating the patient should be there. And who should be not there is a team interested in organ transplant should not be there. So in children, brain death should be declared only after the 7th postnatal day. And the period of observation should be at least 48 hours in neonates and 24 hours in infants, as against 6 hours in adults. And in premature children, brain death declaration is at present not legal. So, and criteria for brain death in 1968, unresponsive coma, apnea test positive, absence of cephalic reflex, absence of spinal reflex, isoelectric EEG, persistence of condition as such for 24 hours, and absence of drugs or hypothermia. And this is a revised classification. So that is 1980, irreversible cessation of circulatory and respiratory functions and irreversible cessation of all functions of the entire brain, including brain stem. Then you got a American Academy of Neurology criteria, 3 cardinal findings in brain death. So various criteria are there: coma or unresponsiveness, absence of brainstem reflexes, and positive apnea test. Then why this is important? Why are you going to demonstrate brain death? That is, avoid unrealistic expectations. A patient is in coma and we are sure that his brain is dead, and unrealistic expectations are given to the patient. So patients will invest all their fortune in a patient who is not going to recover. So that is important to declare brain death to avoid unrealistic expectation. Second, if the family is willing to donate organs, it is very vital for organ donation to save some other deserving patient. Common causes of traumatic brain injury: aneurysmal bleed, intracerebral hemorrhages, strokes, hypoxic ischemic encephalopathy, and fulminant hepatic disease. And commonly we see this. One is a cardiac arrest during cardiac interventions or during myocardial infarction. We know that within 20 seconds, oxygen transport fails in the brain. Within 5 minutes, glucose transport fails. And within half an hour, secondary penumbra, edema, and tissue necrosis starts. So that is very vital following these insults. And as we have seen, people is fixed, no oculovestibular reflex, no respiration, no motor activity, and isoelectric EEG. However, there are conditions which we should remember. People can be fixed with some drugs, and oculovestibular reflex can be absent with some other drugs, and respiration can be due to muscle weakness, and motor weakness can be due to neuromuscular blockade, and isoelectric EEG can happen due to drugs, anoxia, hypothermia. That is why we have the prerequisites which I went through. So all the prerequisites should be satisfied and these parameters should be there. What is this Lazarus sign? These are some red herrings. So patient with brain death can show slow body movements with flexion at the waist, and that is due to rigor mortis. And patient can cause body to rise into a sitting position also. And these are all spinally mediated reflexes when rigor mortis sets in. That is why soon after somebody dies in villages, people everywhere, they tie the jaw, tie the legs, tie the arms to prevent the body going to abnormal fixed postures due to rigor mortis. And this is due to rigor mortis and can happen in the brain dead person. So reflex, what are all the reflex movements you can see in the brain dead? So family might say he is not dead, The doctor said he is dead and he took away the organs. These are not uncommon. These allegations do happen. So these are the features compatible with brain death. What is facial myokymia? Some facial twitching can be happening in a brain dead person. And cyclical constriction and dilatation of the pupil instead of a fixed pupil. That can also happen. That is hippus. And they can have mild finger tremors. And they can have stepping movements of the legs. And they can have intact lower body reflexes. And sometimes eyelid tremors can happen. So all these movements, if they are there, the family will be concerned. They will think that my patient is not dead and the doctor wants to take out the organs. So these are clear features. And so this stiff body going into sitting a position is called a Lazarus sign. And some years back in my own experience, I have seen a lady who died by suicide. She was pregnant and there was some issues. She committed suicide. She was actually dead only. And she was being shifted to the mortuary across a terrain. The old TD Medical College, from the main ward to the mortuary, you go through elevations and depression. It is almost a terrain. That medical college is now not there. It is shifted to another place. So in that place, a physically handicapped employee was carrying this lady to the mortuary. She went into this Lazarus sign and suddenly she sat up. So the bystanders got excited and they thought the patient is alive and beat up the physically handicapped staff who was taking the stretcher and created so much galata. And the next day, the newspaper said that doctors gave a wrong certificate. Patient on the way to the mortuary sat up on the stretcher, drank a cup of tea, and later collapsed and died. That was very interesting. So people can attach their imagination. So we should be knowing this Lazarus sign. So what are all the things which are not compatible with brain death? Presence of ocular movements or gaze deviations. Pinpoint people. We said hippus can happen, but not pinpoint people. And motor responses and grimacing movements should not be there. Then donors after brain death. What is the role? Only reliable source of cardiac transplant. So donors after brain death are the only reliable source for heart transplant. And they can also donate multiple organs. But if the heart is dead, they are not ideal for cardiac transplant. So if you are wanting to take a heart of the person for transplant purpose, donors should be after brain death and not heart death. So physiological derangements of potent poor harvest rates are, so any organ can be taken, but if you want to take heart, patient should be only brain dead. Then physiological derangement and poor harvest rates happens by what is called rule of 100. So systolic blood pressure should be more than 100. Urine output should be more than 100 ml per hour. PO2 should be more than 100 millimeters of mercury. Hemoglobin should be more than 10 grams. And blood sugar 100% normal. So if this rule of 100 is satisfied only, the organ extracted will be very good. So if you want to do a cardiac transplant, the patient should not have cardiac arrest. She should have only brain death. And for other organs, the rule of 100, blood pressure more than 100, urine output more than 100 mm per hour, PO2 more than 100 millimeters per mercury, hemoglobin more than 10 grams, and blood sugar 100% normal. So that is for organ transplant. So this is the certificate format. It is available, you can download. So reversible causes rolled out. Patient is in coma, absent brainstem reflexes and positive apnea test. So you are declaring the brain death certificate. The Transplantation of Human Organs and Tissue Act 1994, that is a Form 8, an act to provide for the regulation of removal, storage and transplantation of human organs and tissues for the therapeutic purposes and for the prevention of commercial dealings in human organs and tissues and for matters connected there with or incidental thereto. So this is an act which deals with how you ethically remove human organ. And that is brain death identified as a form of death. Confirmed by 2 practitioners 6 hours apart and the age not less than 18 years of age. And there is 2009 amendments permitted donations from living near relatives and included grandparents and grandchildren as near relatives. So 2009 amendment of 1994 Act said that near donation can be done by a living near relative and even grandparents and grandchildren can do that. Then again another amendment in 2011, it included grandparents and grandchildren and transplant coordinator of the institution can do that and transplant authority of the government can do that. So extended privileges and rights are given and registered by person with witness earlier or decided by persons lawfully in possession of the body and transplant surgeon or team should not be involved. Transplant surgeon or team should not be involved. Unclaimed body, you have to wait for 48 hours. So there is rights extension to more and more persons by 2011 in view of the option of organ transplant and cannot be taken if the donor is alive and want to donate to a non-relative and authorized authority should approve and hospital should be registered and commercial dealings are punishable by 2 to 7 years imprisonment or fine. So that is in brief brain death, declaration of brain death and organ, what are all the legal formalities. Whatever we do, let it be a very small thing. We are not very big people. So we do it with the hope that somewhere, I am an old person, I am a retired person. So we believe that somewhere this knowledge will help someone to do ethical practice and serve mankind. So that is the purpose. This is what I can do to my mother India. And so this is our pledge. India is my country. All Indians are my brothers and sisters. I love my country and I am proud of its rich and varied heritage. I shall always strive to be worthy of it. I shall give my parents, teachers, and all elders respect and treat everyone with courtesy. To my country and its people, I pledge my devotion. Each one of us can do our duty and a little more. Never fight for doing little less. This is Punya Bhumi, and we are doing a Punya profession, and we will all try to do our duty and a little more so that our mother India becomes the Punya Bhumi of the yester years, showing a role model for the whole world. So thank you. So ethical issues of brain death and organ transplant, hope versus false hope. Brain dead person is there, you are going on treating and lakhs of rupees are spent. So it is a conflict between hope and false hope. Second, a person who is sent home in persistent vegetative state, that is dependency versus death, which is better than the role of organ transplant. Thank you.
Ma'am, one question.
Yes, ma'am.
This criteria about brain death,
yes, sir.
About absence of reflexes, you also mentioned that there should not be any seizure activity.
Yes, sir.
So if the seizure activity is there, what is the meaning of that?
Seizure activity is there means cortex is intact. So
Intact.
seizure can come out only if the cerebral cortex is functioning.
Okay. So it's not completely brain dead.
Definitely not.
Thank you, ma'am.
Yes. Thank you.